All
Okay.
right. Good to
Okay.
go?
Yes. Yes.
Okay. Well, thank you, Martha, and everyone for having me. My name is Lincoln. I'm a physical therapist from at Reactive Physical Therapy in LA, well, El Segundo area. And I've been working with people with dystonia for about 4 years. And for the last actually almost 3 years, I've been the Dystonia Program Director at Reactive. So kind of managing all of the dystonia patients that we see and coordinating care between the different disciplines that we have. And also, since doing that, in the last year, I've been teaching a weekly education class. So we have a dystonia membership at Reactive where I'll teach a weekly class to patients with dystonia, anywhere between 10 to 17-ish people a week. And so a lot of dystonia content and science and conversation that I share weekly. So I have a lot of experience talking about this, and I really enjoy doing it. I think education, both for other physical therapists that don't have as much experience treating dystonia, and then talking to patients is really one of my passions. So I'm really excited to talk with you all, and I think the goal is kind of in the title of the presentation, which is just kind of understanding dystonia of all different types and treating it from a rehabilitation perspective. So I think probably most people have a good amount of experience with some pharmacological treatments, depending on the type of dystonia. So oral medications or Botox and things like that, even maybe DBS in some cases. And I think probably less awareness around the different types of rehabilitation therapy. So I can obviously talk most uh, intelligently, I guess, about the physical therapy side of it, but working at kind of an interdisciplinary clinic, I get to see how occupational therapy, psychology, speech therapy, personal training and wellness, and all of those things fit together. So the main goal is to share a little bit about what sort of the research behind those types of treatment approaches in dystonia of all different types, and just let you know that there are options and hopefully um, point some people in the direction of getting treatment somewhere. And also to show you some examples of patients with dystonia. There's some videos where we can see like what are the types of exercises or treatments that can work with dystonia. Again, talk a little bit in the background about the science of it and why we have the approach that we do, and then yeah, outcomes, like I said. I think there'll be plenty of time to answer questions at the end. There's some patient cases and videos, as I said, that are a couple different types of dystonia. If your specific type of dystonia is not represented in those videos, it will be by the topics in the class. So this should be really relevant for everyone, but I'm happy to answer questions if you're not sure how it might apply in your specific case. And like Martha said, I'll also try to be monitoring the chat too. So Martha, if I miss any questions in there, I can touch on those before our unmuted question and answer at the end. All right. But yeah, thank you again for having me. I spoke to this group. I actually don't remember. It was over a year ago, I think. But it was really fun. A lot of really great questions, and it was nice to talk to people with a wide variety of different types of dystonia and hear your questions. So if you were here for some reason at that one and are here again, there will be a little bit of kind of overlap and review of some things, but there's also a lot of new information in terms of the research that's come out or new kind of treatments or patient videos that we have. So it's not just the exact same thing again. As I mentioned, the Dystonia Program Director. Just a quick little background about me and the clinic and why, who am I? Should you listen to what I'm saying? I knew I was interested in becoming a neurophysical therapist coming out of USC in 2021, and I knew I wanted to work at Reactive because they had a lot of neurological patient cases that you don't really get to see at a lot of other places. And I really liked their kind of cutting edge and kind of interdisciplinary approach. So I thought that was really appealing. And I ended up doing a movement disorders fellowship between Reactive, the clinic I'm at, and UCLA. So I got to work with the movement disorders neurologist at UCLA 1 day out of the week for that fellowship year. And then since then, I've been working at Reactive and the Dystonia program director, as I said, teaching classes. I do few talks a year to either support groups or other physical therapists in our reactive education group. So it's been, I don't have, personal or family experience with dystonia. I do get that question a lot. I think what drew me to that movement disorder specifically was I really liked the people that I met in treating that type of dystonia, and I found it just exceptionally rewarding that you can kind of help people improve their quality of life and really make positive changes with their dystonia when they often have thought or have been told directly that there's really no other options for recovery. I think the one thing I like to make clear up front is that we're not saying that there's a cure for dystonia. We're saying for the majority of people, this is something that you're going to have to manage over the long term. And I think most people know that, but it isn't the case that just because you'll deal with it in the long term that you can't make any improvements. And the brain and body are very adaptable, and you can make significant improvements even to where you're able to do more of the things that you want to do and get back to just a higher quality of life. So that's why I'm here and why I'm talking. So yeah, I mentioned we're going to talk a little bit just about the kind of background science of dystonia. If this is something you know a lot about, it'll be pretty quick. If not, it'll be good information, because I do think it tells us the science of how dystonia happens and what goes into it tells us what the most effective treatment approach might be. And as I said, I think my expertise is going to be much more in the non-pharmacological treatment options, which people don't usually know as much about. So I'll talk a little bit about what we do at Reactive and how we treat it, just from the lens of helping you understand what's available to you. Yeah, so and then just a quick background on our clinic. I mentioned the Movement Disorders Fellowship that was launched about 5 or 6 years before I started and did it. And since then, we've really grown. And when I started as the Dystonia Program Director, we've added a lot of new team members, so speech therapy. Even since the last time I think I spoke to you all, we've added speech therapy, more psychologists, and a couple more PTs and OTs. And we currently have, I think we have currently 8 patients with ongoing treatment with dystonia right now, and we're above about 70 for the year. And personally, I've worked with all of them. So I think even though I think people sometimes are like, do you have a lot of experience? You don't really look that old. I don't look that old, I guess, but I do probably just in the 4 years I've been a PT have a lot more experience because, as I'm sure many of you have realized, there's not a lot of clinics that have experience with treating dystonia or even have heard of it. So that's something that, like I said, we're passionate about. Yeah, so then I mentioned since January 2023, it's been treated over 150 patients with dystonia. We do a combination of standard therapy, so maybe just physical therapy, or integrated team programs, which I think are my favorite part of treating. And that's often really helpful because dystonia is a complex condition. It's a nervous system and a body condition. There's psychological factors, there's lifestyle factors like sleep, nutrition, diet and exercise, social and relational factors can play a role as well. So that's one of the things that I like working with the team and learning about the other therapy treatment approaches as well. So plenty of chances to ask questions about those, and I'll do my best to answer that as well. And just not as, this is not like an advertisement for me or Reactive, but I just really want you guys to see some examples of that there's hope, that you really can make improvements with your symptoms, even if it takes a long time or even if it can be up and down, as dystonia often is. There's actually a lot of people out there making positive changes. So there's a scale that we call the Patient Global Impression of Change. So on average, how much better do you think you are compared to the start of treatment? And since 2023, we have an average of 6.0 out of 7, which is the 6 rating is better and a definite improvement that's made a real and worthwhile difference. So again, just to show you that with the right approach and the right understanding, a lot of people are able to make really good changes. So we'll see some examples of that as well. So I mentioned, yeah, if you know a lot about this, bear with me for a sec. We're just going to do kind of a quick review of like what is really going on with dystonia, because I think it's helpful to to know. But maybe just even by a show of hands, like how many people think that they have a really strong understanding of what dystonia is and what causes it? Great. Awesome. Okay, some hands for sure. So maybe some little head shaking. Yeah, so that, well, good. I'm glad. I think that's really helpful, and I think probably more than even the last time I was here. And I think it really does help you kind of understand like what treatments might be effective. So as you might know, it's the third most common movement disorder in the world. It's characterized by these involuntary muscle contractions that result in different postures or, involuntary movements. And our goal is to try to understand what is really causing that. Now, these are all different types of dystonia that one might have. I've worked with, I believe, all of these types of dystonia. The most common cases that we see at Reactive are usually some forms of segmental dystonia or focal dystonia. So cervical dystonias in the neck, that's one of the most common. I do see some blepharospasm as well. But cervical dystonia and then other focal or task-specific dystonias like runner's dystonia or lower limb dystonia, and also musician's dystonia or focal hand dystonia. So I work with people who have, maybe they're guitar players or piano players or violin players. And then also related to musicians dystonia, you can also have what's called embouchure dystonia if you're not a musician. So certain types of instruments like brass instruments, you have to form a specific facial posture to blow the air through the mouthpiece, and that repetitive movement can sometimes lead to a dystonia as well. So those are some of the most common ones, but I've also worked with people with genetic dystonias or other segmental like trunk dystonias as well. And so, yeah, there's idiopathic. That's probably the most common form of dystonia that we see, but there are many, many, many types, as you probably have learned, hundreds of genetic types and other focal dystonias as well. You can also have it as a complication or a secondary effect of other conditions like Parkinson's disease and Huntington's disease. I do see some of that, or secondary to a traumatic brain injury or a stroke. So all of these are the types of dystonias that we might see. And I think one thing that really underlies my understanding and what I learned both at Reactive and at UCLA during my fellowship about dystonia is just how complex it is and how much is really, to forgive the pun, under the surface with dystonia, where the motor symptoms are obviously the most apparent symptoms. And those are the ones that people usually come to physical therapy or any other type of therapy asking for help with. I would like my neck to stop moving the way that it does. But there is a lot of different secondary and non-motor symptoms that occur with it. And this is probably the thing that I've learned the most about in the last few years, and getting to work with our speech psychology and occupational therapy teams. I've learned a ton about as well, because dystonia is a whole brain, whole nervous system condition. There can be a lot of symptoms that can be related to that for nervous system dysregulation. And so these factors might not be as obvious to people, but they can have a huge effect. So even what's interesting is that even within dystonias that are not, you wouldn't assume would cause some of these things, they might be present. For example, even some people with a focal hand or arm dystonia might have balance issues, or people might have pain and fatigue that is related to both the muscles contracting, but also an additional effect that dystonia is causing directly on the nervous system. We know there's a lot of sensory changes, anxiety, and depression, even beyond, again, just the anxiety around symptoms or depression about changing quality of life. The dystonia directly can cause some of these secondary symptoms as well. So that's one of the things that I think we look about a lot. So, and yeah, and then I just wanted to, if it's okay, Martha, I just did want to touch on what Jonathan was saying. So saying dystonia in my back muscles and also spinal spasms, which my movement disorders neurologists think is related. So I would say, Jonathan, just to real quickly, I would put that within sort of the either like, so under generalized dystonia, that also includes like segmental dystonia. Segmental meaning like, for example, a dystonia in your spine or your trunk. That's totally it wasn't very clearly listed. I agree with you, but that would be kind of under the category of generalized dystonia. So that would be included. Good question though. Um, and yeah, so what do we know about it? What is really causing this? I think what a lot of times when patients come and I meet with them, either for kind of a consultation or they're getting treated already, they will say that their kind of understanding is that we don't really know what causes it. And I think that's totally a fair read of the situation, but I don't think it's the whole story. And I think sometimes as providers, we don't do a great job of explaining it. It is complex, and we don't, in many cases, know exactly what causes it. It's idiopathic, but that doesn't mean we don't know anything about it. We actually know a lot about the factors that can contribute and perpetuate symptoms. It's just also sort of a perfect storm of a combination of some genetic factors, or if you have a genetic dystonia, obviously largely genetic factors, but for most people, some combination of genetic, environmental, and other factors. So experiences that might be highly stressful life events, that might be depression or anxiety might be a factor. It might be past injuries that can contribute to this. But for a variety of factors, there can be a perfect storm with some people where it causes this change in the brain. And so this is a really commonly used analogy, but the idea of it being like a software problem versus a hardware problem. Obvious caveat before I go further with this is that there is some of this software problem going on in some cases, but for if you had a stroke, for instance, or a traumatic brain injury, there's going to be more of a sort of hardware or structural brain issue as well. But for most people, this is more of a software problem. We know that there is areas of the brain that start to form these connections that are not supposed to be there. And that leads to these kind of learned intrinsic networks that cause involuntary movements that are sending constant signals to the muscles to contract when they really shouldn't be. And that sort of misfiring and misconnections of signals leads to kind of further dysregulation where the sensory areas of the brain get smudged and muddled, and your brain is really literally not connecting to the dystonic part of your body the same way it does everywhere else, which makes it even harder to then control the movement. So it's these tangled and confused signals in different parts of the brain. And for most people, if you looked at their brain with an MRI, you wouldn't see anything different. It would look like a normal brain, but if you had a very expensive functional MRI, which are pretty much only in research labs, but if you look at real time, how are the different brain areas connecting, you would see a difference in connectivity. So that's what's kind of meant behind software versus the hardware problem. And as I mentioned, we do know a lot about it. This is the last little bit of like super sciencey stuff, and then it'll be more interesting after this. But there is a lot of different brain regions affected, but especially around sensory processing. As I mentioned, it's like the brain has a map of each part of your body. And if you can think of the dystonic part of your body, that map in the brain is sort of smudged, like it's got something spilled on it, and your brain is just not able to really get a clear signal from that part of the body about what's going on there, what am I feeling, what position is the limb in, which then disrupts the movement output from it. So a lot of different sensory areas can be affected, especially what's proprioception or kinesthetic awareness. So that's some of you might know those terms, but if you don't, the idea is basically where is your body in space. So if you put your arm behind your back and you closed your eyes, you can tell if someone asked you, where's your arm? You'd say it's behind my back. You can feel that and tell where it is without looking at it. That's proprioception. And that becomes muddled or impaired in dystonia very often. So there's ways of testing that in the clinic. And, for example, with cervical dystonia, we can do certain tests to say, how well do you know where your head is in space? And oftentimes it's pretty distorted in dystonia. Sensory discrimination, so just being able to tell where you're being touched, what's touching you. different sensory tests we can do, but also visual and vestibular. So your inner ear sense is often impaired as well, and that can lead to some of the balance issues that we mentioned. So that's the news. And then the good news is that this was a change that for most people happened in the brain through plasticity, where there are these new networks that are formed and for a variety of reasons in dystonia become very sticky and lodged in their pattern in the brain. But the good news is that those normal movement networks are not gone. Those synapses are there. They're just being overpowered by these abnormal, kind of aberrant connections. So there's this overall overexcitation and these new networks that have formed. And that happened because of plasticity gone bad. That not the plasticity we want, but the brain has this capacity to learn. And for some people, it can learn it very well, this abnormal pattern. And that's why there is, some research that kind of shows that actually the people with dystonia of a lot of different types actually might have brains that are in some ways peculiarly good at learning and reinforcing these patterns, which is in most cases an advantage. And there is also some research that shows that, people with dystonias are often pretty high achieving and intelligent. I'm not pandering. That's just what the science says. And I would say that that is definitely my experience too, that I do work with a lot of doctors and attorneys and, people with kind of high-powered jobs that demand a lot of cognitive ability. So there's something about the way the brain learns these things that can lead to dystonia, but we can also harness that and use it to our advantage as well. So with the right tools and environment, we're trying to coax the nervous system back into learning that normal movement pattern. And then I'm okay answering things in the chat. It doesn't really throw me off. And so I do think probably other people had that question. Sorry, what was Liza? So, what is a functional MRI? Who orders it? Can it be requested from my neurologist? So in the majority of cases, the answer is unfortunately no. So, yeah, functional MRI is an MRI that looks at the brain in real time, right? So a normal MRI is sort of a still snapshot image of the structures of the brain. And a functional MRI is looking at the connectivity. So it uses blood flow in real time in different parts of the brain as a sort of a surrogate for brain connectivity. And it works well in that way. And in that way, you can see, okay, maybe there's nothing structurally different in the brain about someone with dystonia versus someone without it, but we can see that actually the different areas lighting up are different. There are connections and pathways that have formed in certain parts of the brain of someone with dystonia that we don't see on the functional image or MRI of someone without it. And so unfortunately that they're not really available in the majority of hospitals. They're only at some research institutes at this time. Maybe in the future they will be more widely available, but in most cases, unless you have a neurologist directly involved in those sorts of studies that wanted to recruit you for a study, it's probably not something that can be ordered, unfortunately. But that's why I think a lot of times, people will get a typical MRI, and some providers who might not be as well versed in what dystonia is will tell them, well, there's nothing wrong on the image, or there's nothing wrong with you, right? But that's a problem with the imaging, not the patient. So yeah, at this time, unfortunately, it's not widely available. But okay, so I'll pause here and slow down a bit. That was kind of the sciencey background introduction piece of it. And I think the key points are about, okay, we know this is a neuroplasticity issue that has occurred. And it's reasonable to think, if that's the case, that maybe a treatment approach focused on neuroplasticity would be helpful in retraining the brain, strengthening those normal connections to try to reduce the intensity and the frequency of the dystonic movements, maybe get you closer back to moving how you did before, even if it's not all the way there. And that, can reduce pain as well, and just kind of get people back to more of the things that they want to do. And we'll see plenty of examples of that. But I think also thinking about our iceberg image that we have, I really love that. I use that like every presentation I have, it's really important because oftentimes factors beyond just the movement, sleep, stress, lifestyle factors, psychological factors, those all might play a role in um, causing the nervous system dysregulation that increases symptoms. So looking at it from a holistic perspective is kind of what is the most supported by the research and that we've found to be really, really the best option at reactive. So that's not the case for everyone. Some people have less of those factors contributing and might do very well with just physical therapy, but there are plenty of options out there. So let's kind of dive in a little bit to talk about kind of what the approach is based on that, a little bit of the evidence that we have, and we'll see plenty of kind of real patients and real examples of what does treatment look like and what's possible. So this is sort of an analogy that we use in our dystonia education to patients and also other providers. So like I mentioned, I give talks to doctors and physical therapists and occupational therapists. And this is sort of an analogy that I think really helps with providers' understanding of it, but I think it works for patients too, which is, again, thinking big picture. There is those specific movement symptoms that you have, but the brain, our psychology, our emotional state, and our movement state, our sensory processing, those are all in the brain, and we can't just sort of neatly separate them. And so thinking about it from a holistic perspective of how do we take care of our systemic health? Am I doing the right things to optimize my health and well-being outside of the dystonia? Because those things often, I think, are neglected because they don't seem directly relevant. But really thinking about setting the foundation, providing the optimal environment really helps with then getting into the movement and the sensory retraining to help prune those connections that you don't want and grow the ones that you do. So based on a lot of this stuff we've talked about and a lot of the research, some of which we'll look at, we kind of came up with this treatment pie chart, as I mentioned, which looks at all of these factors together. So when someone comes in to reactive and they have dystonia of any kind, these are some of the things that we're looking at in these 6 categories of the pie chart. So there's motor control. That one's pretty obvious. Not being able to control your movement, that's clearly a factor. Sensory factor, I mentioned that as well. Looking at a lot of different tests for how is your brain connecting to your body and can we improve that? Psychological factors, as I mentioned, lifestyle factors, the autonomic nervous system. So that controls your level of stimulus and alertness. So there is the sympathetic part of the autonomic nervous system. That's like your fight or flight. Your heart rate increases and it's sort of like that stress response. And then the parasympathetic part of the nervous system, that's your more calm and relaxed state. Now, both of those two states there's always a little bit of each, and it's about the balance between the two. But we do know from the research that many people with dystonia have a imbalance of those two systems where they're sort of chronically more in that fight or flight zone, that kind of constant state of stress, which we know directly causes an increase in symptoms for most people. So part of what we're doing as a treatment approach is saying, let's look at changing that. Can we get the nervous system to regulate back to a better balance? Excuse me, physical limitations. So some people would look at that and say, well, I thought you said this is a brain condition, this is a nervous system condition, and it totally is. The brain is where the problems are occurring. But we do know that injuries and physical limitations, past history of physical, problems, just like with other types of problems, that can lead to some of the changes that occur. So, for example, I work with a lot of people with runner's dystonia, and it's more common than I would think would happen by chance that they had some sort of serious injury on the affected side or sometimes the non-affected side within, the year or two leading up to developing the injury. And so how might that happen for people who are maybe predisposed to developing dystonia in the first place? That sort of injury, maybe it changes the way that they move, or because maybe they're in a boot or something and it changes the sensory connection that they have to that limb. And that might be things that sort of start to push people over the edge to where the symptoms start to present. So it's a neat, even pie chart in this picture, but that's not how it is for anyone. No one is, people aren't like that. And for some people, they might say, well, I don't really think I have like psychological factors. And sometimes maybe they do that they haven't realized yet. But in some cases, I'm not denying that that's totally true. Everyone's pie chart is totally different. Some people might have a huge chunk in one section and less in the others. And our job as providers, I see it as trying to figure out what are the factors that are contributing for this individual and how can we work on it as a team, and collaborating with their other providers if they have outside providers to try to give the best environment for them to make some improvements. So quick recap of the evidence. So we have just some of it. This is not extensive, but just so you guys kind of know, I'm not just making this up. There's research on a lot of different types of dystonia that show that not only is improvement possible, there's specific things we know about treatment that are really helpful, and it can be maintained and even improved on long term. So sensory motor retraining. So that's looking at the movement and the sensory retraining. There's a lot of different studies on it. Nancy Beal is a great researcher at UCSF who looked at a lot of different types of focal dystonias, but specifically hand dystonias. So writer's cramp or typing or musician-related dystonias. Did a lot of different studies, and in 2008 there was a big study she did that showed, clinically and subjectively significant improvements in the participants' ability to play their instrument and to write and type and do other fine motor activities with their hands over 8 weeks. And that was a lot of sensory and motor retraining. So getting at that neuroplasticity approach, how can we get the brain to connect to the dystonic limb better? Rehabilitation that includes fun, varied, and challenging practice appears most effective for maximizing plasticity. Not related to her, I wish I was, but different Beal. And then there's some systematic studies on both focal dystonia and focal hand dystonia, excuse me, and cervical dystonia that show that, an addition of rehabilitation treatment either on its own can be really effective, but also in addition to Botox leads to significantly better scores in pain and movement control. And yeah, the neck vibration and proprioceptive training. And then looking at the interdisciplinary approach. So we know for some of these studies, looking at all different types of dystonia, oftentimes the non-motor symptoms might be actually bigger drivers of reduced quality of life or challenges that people report. Yeah. And then there's other studies showing that actually behavioral or psychological treatment approaches can be helpful, especially when it's made individualized and specific to dystonia and specific to the person. And yeah, again, this interdisciplinary approach, looking at kind of bigger studies on this, we know that adding the multiple therapies together generally has an even better positive effect than just one therapy on its own. And people with this interdisciplinary treatment approach, not only do they report improvements in their movement symptoms, but also things like social interactions, sleep, confidence, and self-efficacy, and things like that. So plenty of studies that this is not comprehensive, but there's a lot of evidence showing that, okay, this can be helped. This was a study that came out this year that I was really excited about because there was this initial study, I think a few years before, or 7 years, it says right there, before that, was looking at this focal dystonia, doing this sensory motor rehab program, and it showed really significant improvements both at 12 weeks and then 6 months afterwards. But I do get a lot of questions from providers and patients like, okay, but what about long term? Like, does that go away? And this was the follow-up study I was really excited to see about. And what it showed was that for all the individuals in the study, it was between 24 and 30 patients in the study, that long-term follow-up 7 years later, every single subject participant showed significant improvements in their symptoms while maintaining their treatment program on their own. So no supervision. was required, and they were able to keep doing the exercises that they had learned. And all of them except one had improvement at all of their fine motor activities, including playing their instrument, just even without supervision, which I was really excited about this because one, it just shows that, again, these improvements can be maintained long term if you maintain working on it. But my goal really as a therapist is um, I want people to reach the point where they're empowered to do this on their own and feel confident doing it on their own. Being, unfortunately, one of the few clinics that really specializes in treating it, I've gotten to work with people from all over the country, like, 30 different states of several different countries. And that's just the experience of that obviously leads me to want people to be independent because I can't always follow up with them long term. So our goal is to develop a program together that they can do that fits into their routine and their busy schedules that they can maintain long term. So this is really encouraging for me to see too, to provide them with that confidence that yes, you might feel a little nervous at first doing it on your own, but you can do it and you can make further improvements. So yeah. Okay, so here's just like this is kind of the dystonia freebie that I made for people. But just to give you some ideas, you don't have to do this right now, but we're going to get into treatment now and some kind of we'll look at some videos of patients who are doing real exercises so you can see. There'll be some of each type of discipline, but mostly obviously I'm a physical therapist, so we'll see a lot of physical therapy exercises. And as I said, feel free to if you have a note in the chat to ask. But once we've done our assessment with people, we make their sort of treatment pie chart. We say, here's what I think would be the most helpful for you based on what we've seen. And oftentimes in that first evaluation day, we go through some tests, but I also try to give people some exercises to get started with and some things to show you the brain's capacity to learn different movement. So with motor control, what we're really trying to do with dystonia is a couple key things. We're trying to say, okay, there's this movement pattern that occurs maybe in specific postures or positions. So maybe it's more standing versus lying down. Maybe it's while you're walking. Maybe it's while, task specific, while you're playing an instrument or typing or drawing or things like that. Or maybe it's all the time. But even if it is all the time and more generalized, there's specific things that we know that can change the way the brain moves. So these are just, again, you don't have to do this right now, but some ideas that I'll let you take home with. And you should have plenty of ideas from the videos too. But some of the things we try is we might use what's called an external focus of attention. So has anyone heard of that before? You can raise your hand if you know. Do you know external versus internal focus of attention? Have you heard that as a concept? Okay, so a couple people maybe, but so in general, the idea is that with dystonia, we know the brain circuits most affected are the voluntary or intentional motor circuits versus the automatic movement circuits are generally less impacted. So what does that mean? With an internal focus of attention, let's use cervical dystonia as an example. Let's say maybe turning your head to the right is difficult. If I just said, okay, turn your head to the right, that's probably not going to work very well. The internal cue is thinking about your body part or your muscles and trying to make the movement happen. That's probably pretty hard. If I said, okay, I'm going to toss this ball to you over on that side, I want you to turn and catch it and catch the ball like that. Generally, that will actually be easier and people will have a greater degree of range of motion because we're tapping into those automatic movement circuits. That's one aspect. Changing the sensory input can also change the movement pattern. So that might mean putting tape or vibration, changing position. So like trying the same movement lying down versus standing up, or reclined versus seated upright. Those sorts of things can all play a role. And then one of the other pieces is, yeah, making it kind of challenging and complex and variable. So variability is really, really key. We know that, as I mentioned, dystonia is sticky. So what I mean by that is the movement pattern gets ingrained and we can do a lot of exercise to try to retrain the brain to have more normal movement pattern, but it can, it often it will return and it is this sort of constant push and pull. But we know from the research on it that variability is key. So doing a variety of different types of exercises using different sensory cues throughout the day and not just always using the same one, it actually helps sort of trick the brain and keep it guessing in a way that makes the dystonia less intense over the long term. So one thing I like to do with people is use like we call it an exercise jar or a variability jar. So maybe we have a group of like 20 or 30 exercises, all of which we found have really helped this person's dystonia while they're doing them. But that might seem overwhelming, or a lot of people kind of hyper fixate on one or two exercises they really like. And so to help with that, we'll take part of the session, we'll write down all your exercises on a little sticky note, put them in a jar, shake them up, and say, okay, we're going to do a workout with 5 exercises, and they'll pick 5 of them out. So that's just an example of how to incorporate variability, because I think sometimes it can be like, I have all these exercises, this is overwhelming, how do I pick one? So that's one way that I actually learned from the OTs at the way I work with that I think has worked really well. But there's a couple just quick ideas that I often try on the first day with people is using different sensory cues. Maybe it's a hand dystonia. Use a rubber band around a couple of fingers and then try typing again, or then try playing your instrument again. Or oftentimes one that works very often is I'll put like, yeah, rubber band and then like a cotton ball between 2 fingers that are dystonic. And all you're doing is just changing that sensory input where your brain is not really connecting to that part of your body, but you change something. So now your brain is like, okay, actually, I have a little more information now about where my hand is, and that might help improve movement. Other sensory examples for runner's dystonia might be, putting a loop resistance band around your knees and then trying to walk, or adding an ankle weight on the top of your foot to sort of give a different cue to lift your toes up. Cervical dystonia, we have a lot of different like tape and vibration. There's like these little vibration patches that go on that can like stick on your body. And so putting it on different neck muscles, oftentimes that will, again, just give a different cue to your brain to move better. But these are some of the other external cues for runner's dystonia. I often try this one first is saying, okay, if your foot is going down and in as you're walking or running, tape a cup with a little bit of rice on the top of your foot and just say, okay, don't spill the rice. So that's an external focus. Instead of saying, lift my toes, you're saying, don't spill the rice. And that accomplishes the same thing, but it does it better because you're using the less affected circuits. And then cervical dystonia, as I mentioned, maybe tracking a ball, using the head laser lamp to move to different targets is another one I really love as well. But we'll see plenty of videos. And yeah, I did actually want to touch on Craig's question really quick because I get this one a lot in the consults I do with people and actually patients I worked with. I think a very large percentage of the patients I've worked with at Re+active have at some point tried Dr. Farias's program. And so I will, obviously upfront say I've never participated in it and I'm not an expert in it at all. But I do think that there is certainly some overlap between the two treatment approaches. I think from what I've seen of it, there's a lot of focus on kind of variability in movement and kind of enjoyable, kind of fun, different types of movement that are varied and that are trying to get at getting a little bit more normal motor control through those sorts of approaches. And I think he does tend to have programs that involve some sensory components, autonomic nervous system components as well. So there's probably some overlap. But I think also just from the people I've worked with, there's definitely some differences as well. Which again, I'm not an expert and I haven't done his program or anything like that, but oftentimes there's some things that I'll try with someone that they might have tried with the Dr. Farias's program. So yeah. Okay, we'll look at a couple examples and then we're going to look at a little bit more after that into some specific cases. And as I mentioned, I think happy to, if you're at the end or if you wanted to put it in the chat, if you see something you're like, okay, that was that type of dystonia, like maybe, but how does that apply to my specific type of dystonia for me? And I think my goal is I included a lot of different types of dystonia in these videos so you can see, but the principles are really the most important thing. So it's the ideas like the sensory inputs that can help you retrain your brain, the movement cues that can help you retrain your brain. It's those principles of saying, how do I use an external focus or sensory input that are the most important rather than like the specific ways we do it. So any type of dystonia that you have, I think there's ways to get some things out of it. Okay. Am I going too fast, Martha? Or are we good so far? Okay, cool. All right. So yeah, we'll look at some different examples here. This first one, I think, is not showing me the thumbnails, but yeah. So this is someone with runner's dystonia. And I'll pause it for a sec, but what we're doing here is actually using, and we'll look at some other mirror training exercises as well, but we're using the brain's ability to use mirror neurons. So the neurons in your brain that can observe a movement and then copy it and learn how to do it. So you watch someone do a dance move and then you're like, okay, it's like I'm going here and then here like this. Okay, it's how you watch and then copy that movement. So with dystonia, that can be harnessed by having someone look at normal movement. Maybe it's a mirrored image of their unaffected limb doing a movement, and then that can lead to more normal movement on the affected side. For runner's dystonia and for walking related to runner's dystonia, what I'll often do is I have these videos of me or someone else walking from a POV perspective, so looking down at your feet walking, and I'll have someone then with runner's dystonia walk they're normal, and then say, okay, hold the iPad, and I want you to just watch the video of my feet walking and try to copy those steps. And it will often lead to a lot better movement for them. So this is just her watching my feet walking and trying to copy the steps. And you didn't see other videos of her yet, but I think unless you have really good eyes, it's actually kind of hard to tell which foot is more affected by the dystonia. So it's looking pretty good. So that's one example of how that can be used. I think the other thing, just as we're looking at all these different treatment examples, is okay, you showed us a million different ways of, and maybe you buy it that, okay, there's actually ways to improve my movement, but what about long term? Here's how I like to think of it. The analogy I really like to use is like training wheels, right? With maybe there's all this crazy sensory input, or we're changing movement a little bit to have it be more normal, but you're like, well, I'm not going to just walk around with this mirror video of my feet all day, right? Or I'm not going to walk around with this ankle weight on my foot or vibration on my shoulder or things like that. Totally correct. But the idea is that for dystonia to improve, all you need is to have a little bit more normal movement each day, each week, each month than you did before. And if you're starting to increase the percentage of normal movement that you have, your brain is getting closer to having that be more of the default movement pattern rather than the dystonic movement pattern. So if you can just have a little bit less dystonia repetitively over and over time, your brain can start to reestablish that as the normal pattern. So just like training wheels, you bike with training wheels for a long enough time, and eventually one day you take them off and you can just do it. You can just bike without the training wheels, even though you've never done it before. That's the same way I like to think of it with dystonia, that over time, with a lot of repetition, you can get to the point where you don't need these different cues and tools as much as possible. But in the meantime, they're helping. They're helping your brain to rewire and relearn that normal pattern. And so Tony is asking a really good question about why does it affect different body parts? So, why can you have spasmodic dysphonia, face, hand, etc. And I don't think that's not something that we have an understanding of. I think that's one of the kind of key mysteries of dystonia. And even though there are some genetic forms of dystonia that tend to affect certain body parts. It's not clear from the genetic science why those specific body parts are often affected. But all we can say is, why, functionally, why is it happening? It's because those areas where there's those mixed signals in the brain, where those are occurring, are the areas that control the sensory information and then the motor output to those body regions. But deeper than that, why specific areas, it's hard to say. And this is another example of external focus of attention and changing position. So again, we'll look at some cases where we can see more of one person, but this is an example of someone who they're trying to turn their head side to side with their cervical dystonia very hard, a lot of tremor, and a specific limited range of motion going to their right, I believe. So we said, okay, how can we get your brain more repetitions of normal movement? And we found that going quadruped, so hands and knees, that significantly improved how much range of motion they could have. So we said, great, let's start there. And over time, we're going to have you move closer to fully upright or while you're walking or driving, where you have the most difficulty. We're going to start where you are, where we can get some more normal movement and gradually build you up. This is also an external focus example where we're using that head laser lamp. I love these things. There's a little laser pointer at the end of it. And we're just saying, instead of telling her to turn your head to the right or left, we're saying trace along this band on the floor. And she was able to go, a lot further with that cue rather than just thinking about her neck as an internal cue. And you can see like pretty good. I mean, but going both ways, it's about the same. So that's another one. This is someone with a hand dystonia. So he is a musician, he's a drummer, but so he had dystonia that developed in his hand starting with drumming while he was in high school. But then when he came to us, this has been going on for a few years. His problem was actually, I work at a desk job and I have to write a lot of things with my left hand, and I also have to type a lot. So both of those movements were becoming really affected. So this is just a really easy, simple sensory cue that we found, and where his fingers were curling a lot as he was trying to type. We just put a little bit of change in sensory input with this putty. So this is just yellow putty, wrapped it around his thumb. And again, my explanation for that is it's saying, okay, more proprioception. Hello, brain. You're not really sure where your hand is. Now you put the putty on it and it's giving more information. So the brain has a better sense of where his hand is. And you can see just using that simple cue, he's able to control typing pretty well, where you can actually still see it, right? He has this little kind of tremor in his thumb, and then his fingers would sort of curl like this. But that little sensory cue helped a lot, reducing it. This is the one I mentioned on our free Dystonia Ideas page of walking with the rice in the cup. So they have a little cup of rice taped to the top of her foot, and this was, I think, one of her first days, and she was like, okay, actually, I can actually land on my heel. And she's like, I was like, well, your walking still looks pretty stiff, right? It's not what we would call normal yet. But this was really the first time that she'd been able to kind of land on her heel just by using that simple external cue. So you're seeing a lot of little clips of, okay, I see that there's some exercises that can help, but we'll look at some cases too to illustrate that actually long term, if you maintain these things, you can actually really improve and reduce your dystonia. Okay. Yeah. So again, this is our treatment approach, thinking more externally focused versus internally focused. So looking at not just chasing symptoms, but looking big picture. Let's, kind of together kind of looking at some of the specific ways that we can do that. So yeah, I'll show. Sorry, this is. Okay, yeah. So here's like our team, the team members that I mentioned. We have all of these different components, and we do a consultation, we do an evaluation, and we say, here's, if the consultation indicates that you'd be a good fit with reactive, let's say, okay, now these patients are coming for their evaluation. We'll go through those pie chart sections as either just me or as a team during the other therapy evals, and sort of assess, okay, and then we'll collaborate with the patient and say, this is what we think your pie chart is based on what we've seen. And we're going to focus a lot of things on those specific pie chart sections. So the assessment drives the treatment. If we find that it's like, wow, your sensory processing is really impaired, we're going to do a lot of work on that probably. If there's not as many psychosocial factors, maybe we don't spend as much time in those areas. Oftentimes there's autonomic factors. We're going to look at those, but based on what we see as a team, we're going to say, here's what we think your pie chart is right now. And maybe it changes over time, but we're going to really drive your treatment based on that. So I promised you some cases and some examples of things that you can see and sort of see what does it look like in practice. So this was a case that I did bring to you about a year ago, the last time I talked to you. So there's some new slides related to it and other things. But if you were here, this guy might look familiar. The other two are not familiar, but this is one example. So this is an individual, JD, with cervical dystonia. Said he was diagnosed 2 years before he came, but he was, in hindsight, he said probably it had been going on for, more like 5 or 6 years. So his dystonia specifically caused like a retrocollis primarily. So, or at least that was what was most impacting him. So causing a backwards extension of his neck, a lot of neck spasms and pain. He had some tremor and a little bit of kind of a rotation, excuse me, and side bend component as well. So and he worked in it was Honda factory as a factory worker on like the line. So he was doing a lot of manual labor, so assembling parts that would come from side to side. He'd have to lift, bend down, turn and grab things, and kind of he's doing that for hours at a time. So you could imagine, even if you don't have cervical dystonia, how hard that might be, with also, your neck fighting back against you. He was also, really, really bummed, because he is a super active guy. So him and his wife would go lift weights, they would kayak, and do just go for walks outside. And all of those things really had become way harder. And he was kind of avoiding a lot of them by the time that we met him. So our goal was to say, okay, we're not trying to make your symptoms be zero, but let's see if we can give you the right exercises and treatment to reduce the intensity and the frequency, reduce your pain, and get you back to doing those things more easily. So we'll start with kind of small goals, like he doesn't feel like he can hike at all or any more than like a quarter mile. Let's try to see if we can get you to going half a mile before you need to take a break, and then a mile, and keep working on that over time. And same with all of reading and his other goals as well. So from the physical therapy perspective, going back to the things we mentioned that can be related to symptoms, we looked at a lot of different things. We looked at balance. So because especially with cervical dystonia, there's often vestibular factors. So your inner ear can be imbalanced, or your brain's processing of inner ear vestibular input can be imbalanced to the point where your brain actually starts to perceive this kind of twisted or tilted baseline posture that you have as straight. And that can be part of the reason then it becomes even harder to get your head actually straight, because to your brain, it doesn't feel straight. We use that head laser lamp for one of my favorite tests. I think it's really informative, which is called joint position error. So if you want to, you can participate in this little class activity, but just to imagine what this test is doing. So I'll be the patient here. So what we say is we have this laser on their head, this second picture here with the little red, green, yellow target. So they start sitting facing exactly straight, and with the laser in the center of the target. And then I'll say, okay, I'm going to have you turn your head to the right and then come back to where you feel like you started, where the center target is. And once you feel like you're there, open your eyes and check. And that gives us really cool, like real-time feedback we do 3 repetitions, right, left, up, and down. Real-time feedback of where is your brain? Can your brain tell where your head is in space? And oftentimes, compared to people without dystonia, this is impaired. And it's a cool test because you can track your improvement in it over time. And usually as people are getting closer to sensing actual straight ahead position, their symptoms are also decreasing as well, because their brain, that's the rewiring happening. And then I also love the laser because you can then use it for different exercises, one of which you kind of saw a way to do that already. Balance, we looked at strength, we looked at sensory processing. So how well is your brain connecting to that part of your body? This little thing in the middle is just one example of how we look at the autonomic nervous system. So heart rate variability is one way of looking at that. Has anyone heard of heart rate variability by show of hands? Maybe not. Yeah, there's okay, cool. Cindy's putting her hand up. Yeah, there's no reason you necessarily would have, but basically the idea of heart rate variability is, as I said, a measure of the autonomic nervous system. So how are you more in that sympathetic or parasympathetic zone? The Leaf is called as one device to do that. We're not like, I have no financial connection to them. That's just the one that we use in our clinic. There's other versions, but it's just this little device that looks at your heart rate variability. And when if your heart rate is 60 beats per minute, it doesn't actually mean that you have a beat at 1 second, 2 second, 3 second like that. It's not, it's an average. And so there's actually some variability to it. And when there's more variability, that's an indication that you're more in that kind of calm, relaxed zone. And when you're in that sympathetic fight or flight zone, the number goes lower. That's not a bad thing. We're not demonizing the sympathetic part of the nervous system. You need that. If you're exercising, it should go lower, your heart rate variability. It should be a more sympathetic. If you're, running from a tiger, it should also go lower. That means you're appropriately increasing your heart rate. But for many people with dystonia, as I said, they're kind of chronically in that low state. So we look at what is that kind of baseline state. And then if we do different, maybe breathing or other sensory things, what things increase your heart rate variability. And oftentimes that correlates with better, with fewer symptoms or less intense symptoms. You can track it on a Fitbit. I think there's other devices as well. I know that for Fitbits and I think for Apple Watches, I think the technology is improving, but there is a little bit less direct accuracy with those versus some of the other devices that you can like strap around your torso and like under your heart. Those generally have a little bit better accuracy, but if you're just trying to understand, trends or kind of big picture what your heart rate variability is, I think from at least what I've seen with like Fitbit, Apple Watch, or Garmin, some of those watches, those might give you good information too. Okay. So yeah, we talked about this. So what happened is actually in 4 weeks, he made huge progress. And so he did PT 3 times a week, psych 1 time a week. He did yoga therapy once a week and occupational therapy twice a week. So over the course of 4 weeks, we looked at all of his different goals and in general. So we asked him to rate, I think it was he set his goal. It was, I think, returning to work, lifting weights, and I think it was reading and playing guitar. So on average, we said, what's your confidence in doing those activities on a scale of 0 to 10? 10 being, I can do that activity exactly how I want to. 0, can't do it at all. So on average, he was at 13%. So meaning his average was reporting a 1.3 out of 10 confidence. So not great. And in 4 weeks, that increased to an average of 6 out of 10, which is huge. I think that's really like really dramatic progress. And at the same time, I think it also shows 6 out of 10, a lot better than 1.3 out of 10. It's still not great. I think, and I'm not showing this as like an extreme example. There's a lot of people who can make this type of progress, but it also shows that he's still a work in progress, right? He's not where he wants to be. 6 out of 10, that's not great if you started at 10 out of 10. Huge improvement compared to where he was, but also just shows that, okay, we know that, a month, that seems like a long time to some people, and it kind of is if you're doing therapy a lot, but that's really just the foundation of his long-term goals and his long-term recovery and figuring out his symptoms and how he can manage them and improve them so he can do even more of his goals. So yeah, he made a ton of great progress though. Let's look at some of the things that we did with him. So loading very slowly. Okay, so this so posture and sort of adjusting his posture was a big thing that we found made an impact. So sorry, excuse me. In OT, we looked a lot at his ergonomics. And so when he was the small part of his job where he was at a desk or a table, or if he was at home reading, we found a bunch of different things that actually allowed him to look down without his head tilting back much better. So we found adding additional support and input behind his back and changing the way that his back was aligned actually put his head, changed enough about the input to his brain that he was able to look down better. So this sort of setup in that, excuse me, picture on the far right was much better for him driving and reading and playing guitar and things like that. We also looked at in PT with motor control. So what you'll see here in a sec is that he's got on the head laser lamp doing one of my favorite exercises with the head laser lamp. So trying to help people, especially when they have a lot of tremor with their movement, saying, okay, I'm going to have you try to trace this, maybe these lines or this kind of star pattern. And that way you can kind of get direct real-time feedback for the patient about how much is my head tremoring or how much am I keeping it still? Because if it's deviating off of the line significantly, you'll know that you're not, keep controlling it super well. You'll also notice a couple other things here, maybe you didn't, but sensory things that we found really helpful for him. He had told me that, okay, when I notice when I'm swimming, I have much better control of my head. And I was like, that's interesting. Okay. Maybe it's something about the arm movement that's helping. But I couldn't really figure it out until I asked him if he wore anything on his head. And he said, yeah, I wear this like skull cap. And we found that actually just wearing that skull cap as a sensory cue, some sort of compression, really helped improve his movement. And also, the other thing around his neck is this cooling towel. Sorry, guys. I don't know if you've ever used those, but they stay cold. Sorry about that. Oof. Oof. Okay, sorry about that. Um, they're cold, and that was also a really good sensory cue. Thank you. Sorry, I think I accidentally hit the mute button and then it wouldn't let me do it. So thanks for bearing with me. Sorry, I don't know where that cough attack came from. But so what you can see him doing here was I mentioned looking down was really hard, right? So walking down the stairs was a big challenge. We found that, again, using this cooling towel as a sensory cue really helped him look down better. What he's also doing here is a dual task. So changing the focus from just on his neck to an additional dual task is often helpful in dystonia. For him, he knew a lot about cars, obviously, but also different rock bands. And so I had him just list rock bands alphabetically, and he was doing that. That actually helped him do the movement a little bit better as well. Here is an OT, kind of combining a bunch of things together. So one, we said, okay, for everyone, if we make the environment as like fun and specific to them and nourishing from a nervous system perspective as possible, we know that not only does that make it more fun for them to come to therapy, but it actually has a direct effect on movement. And so providing people with different choices and different interests as part of their program is always something we try to do. So I would let him choose the music for our sessions, and we would do things that got him to laugh and have fun. And that actually is, again, more fun, but provides a real movement improvement. And so other things you're seeing in this video, so external focus of hitting the balloon, back and forth sensory he's holding a vibration ball over his neck muscles, and that was a really good cue for him that helped him avoid his neck going back. Also, vestibular input just from sitting and bouncing on a ball. So if anyone hasn't tried that yet, if you have a cervical or a trunk dystonia in your back, oftentimes I'll have people sit on a bouncy ball, and that will actually improve how they're moving. For some people, it won't. It's obviously very individual, but for him, that was one thing that really helped. So just some examples of how we might treat it. And so, he was really made a lot of great progress. And, in sort of 4 weeks, if we work with someone, not everyone gets that, 50% almost improvement at all of their goals, but everyone gets some improvement. And I think, how long it takes people to get to that level of improvement can be really varied. It might be harder for some people. There might be more ups and downs. Some people do it quicker. But what we do know from experience and from the research is that if you have the right treatment approach, and if you continue it long term, you have some sort of rehabilitation program and exercise program, and you continue that, in the long term, you can maintain and even continue making progress. And so he has, continued to do that. And just to show you, not to hype ourselves up, or me specifically, but to just show you that if you're feeling let down or like, you haven't really had any success, it is possible. It doesn't mean it's easy, but making significant improvements is totally possible. So we're going to look at a couple more cases, and I'll be happy to, again, answer anything in the chat if you have it. One other cervical dystonia case, and we'll look at one other one just to show, again, some more examples of ways that we treat it. Whether any of you decide you want to talk more about reactive or not, maybe you have another physical therapist who maybe doesn't know a lot about dystonia, but they're open to learning. And you can say, hey, I saw this exercise in this talk I went to, and do you think we could try that? Or, hey, I learned about like adding sensory input can be helpful. Maybe I'll try that on my own or with your other therapist. Or, maybe I haven't tried occupational therapy, but that sounds like something I would like. So that's kind of one of my goals. So this other case we'll look at, so this is another woman we worked with cervical dystonia for a little over 4 years. So you can see what kind of baseline posture is tilted to the left and a little bit of rotation then to the right. And her main goals were to get back to work. She had stopped working as a life coach a few years back. She wanted to walk with less pain, write and use her computer more comfortably. And also, one of her bigger picture goals was to play pickleball, which she had tried all these things pretty recently, and they'd all gone poorly. So she was having a ton of pain, a lot of tremor. And so that's where we started with her when she came in. So we looked at a bunch of different things, but just so you can kind of see how she was moving sort of at the start. So this is kind of how she was walking. You can see a lot of that dystonic posture is present there. And, that really limited her ability to go and do, social activities with her friends, just because you're going to the mall or you're going shopping or you're hanging out with your grandkids. It involves a lot of time on your feet, and just like social situations too in general were really hard. So this is kind of big picture, like treatment plan. We found, okay, we're going to do some vestibular stuff, some visual stuff, work on proprioception, and a lot of physical limitations that we wanted to work on. She'd had some back and hip issues in the past that, we could theorize were probably leading to some postural compensations that might have, contributed to the development of the dystonia or might now be causing it to be worse. So those were some of the things we looked at. So I'll show you a couple of examples. So physical limitations, this is a brain thing, but not neglecting that. We looked at trying to improve her range of motion, rotation. Right, so we found changing position for her was really helpful on its own, just supporting her head. And she could do a lot of exercise that she couldn't do standing up in this position, so lying down. Side bending as well, we found, if we're trying to stretch her back up in a more upright position, couldn't really do it. But in this position, more support, but also, again, using that external cue of saying, okay, I just want you to follow your hand with your eyes. That little bit of a cue change was helpful for her to get more rotation. And then here doing some more variable movement to try to get some more mobility. She had done yoga in the past, so I was like, okay, well, I don't know anything about that, but let me look up some things that I think would be good for you specifically. I think it should be illegal to have to listen to your voice on recording. It sounds so different and more annoying than I imagine it. But that was some of the stuff we did. We looked at posture, of course, and saying, okay, how can we change your posture that might make your dystonia better, but also make it easier to get through your daily activities? So we did a lot of training with different inputs, including just like having more support behind her head. And then gradually, like that training wheels example of gradually taking away all of the different sensory inputs that were helping and saying, okay, now that has your brain really relearned that normal movement pattern so that you can maintain it even with less sensory input or cueing. These are a couple exercises that show just again some of those concepts in practice, and you guys can feel free to steal any of this. That's the goal. For her, we found that okay, a lot of vestibular components here. We found that using the head laser as an exercise was good, and that external cue did help her get more rotation than without it. But we also found that, as I mentioned before, her brain's perception of where her head was actually tilted. Like when it was tilted to the side, her brain was saying, that's straight, we're good. And so what we're trying to do is actually give different cues to show, no, actually, you're wrong, brain, sorry. And using this tilt board is a great example of how to do that. So we found if she was either tilting back and forth, side to side a little bit to give more vestibular input to the brain, or just actually holding it down, tilted to one side, it just tweaked enough the way the brain was processing where her head was that it improved her movement. So you heard her say, yeah, that was easier. And so she's just like tilting a little more to the left with her body. That helped her neck rotate further than without it. So love the tilt board. It's just great for balance too. And I use it a lot. This is one of my favorite ones to use for people with cervical dystonia, but to retrain that sense of your head being straight ahead. Um, so just looking straight ahead with the laser, oftentimes, people will still not have a great sense of where they're straight or not. So doing that closing your eyes test and coming back is hard, but we can use different input, so body on head rotation, to help train that sense. So what we're doing is saying, okay, I want you to keep the laser on that target straight in front of you, and I want you to turn your body underneath your head side to side without letting the laser come off. So now what you're doing is two things. One, you're giving input to help your brain figure out where straight is. Two, you're actually tricking the brain into rotating your neck more. So you can imagine, right, if I do this, that's one thing. But if I just turn my body and keep my head pointed towards you guys, it's doing the same thing relatively. My head is now turned relative to my body, but it sort of tricks the brain to do that a little more easily. We'll see her doing it. I just wanted to mention briefly in a second that you can use this sort of thing for any type of dystonia. So let's say it's like a runner's dystonia. Sometimes I'll do things where I'll tie the laser to the top of their foot and say, okay, close your eyes and try to like march your foot up and down and try to keep it pointed on the target. Or for trunk dystonia. So forgive me, I forget who it was. I think Jonathan maybe was talking about dystonia in back muscles. So that's definitely another one. I've done it. People have twisting or spasms in their back muscles. You can strap the laser just around your trunk and do something really similar. So kind of rotate. You can either, turn your whole body back and forth and try to get it back to the target, or you're only limited by your creativity. Any type of dystonia, I think you can really use it. Blepharospasm would be hard. I'll give you that. But for most types of dystonia, you can use some sort of laser cue like this. And even in like blepharospasm or even small muscles, you can use a lot of the same sensory cues and things like that. So we can see her doing it here. Yeah, so she's kind of getting further as well as kind of training the brain. And I think, Diane, I'll try to answer your question pretty quick, but feel free to, ask it more at the end if you want to elaborate. But um, so there can be some connections. None of these I would say are from my, I haven't read every single article about dystonia ever, but there are some movement disorders that might be more common when there's other specific autoimmune factors present. So there are I think a few types of dystonia that are slightly more common in people with autoimmune conditions like lupus or like, yeah, giant cell arteritis or um, I think, like antiphospholipid syndrome, but that's not super common. But I think there is definitely some signal that there is some kind of connection between, autoimmune disorders and some types of dystonia. So maybe to answer to answer your question for the last part, maybe I can't say for sure, but I don't think it's totally crazy to think that. And Diane is asking a really good question that I would have gotten to anyway, but I think this is a good time. So are some of these therapies more productive on younger people versus older people? Not any more than any type of exercise is. So I would say that the brain, capacity to learn and relearn normal movement, maybe there is some difference on average between younger and older people. I will say, just in my experience, I worked with people as young as 8 with dystonia and as old as 85 with dystonia, and I haven't noticed any sort of consistent trend. Now, you might have a little bit more limited options in terms of what exercises you're doing if you are someone who's much older compared to like a very active person in their 20s. But in terms of how well the brain is able to relearn the normal pattern, I really don't. There's not really any evidence that there's a significant gap. A couple more for her. We'll look at a couple more videos of another case, but I promise I'll leave plenty of time for questions and answers at the end. We're almost done here. So again, looking at setting up the environment. So a kind of darker room for her helped her have a more calm nervous system, supporting her in this position, and also using these external cues of rotating to tap the cones versus just turning her head was really helpful for her. And then this is another example of trying to use sensory input. So we found that actually holding a weight or a water bottle in this case in her left hand just changed the input enough to her muscles and probably to her inner ear that helped her not tilt as much. So she's using this kind of the visual feedback of like the window in front of her. She's looking at her reflection and then doing an exercise that was pretty hard, which is sidestepping. But first you can see the cue is just, okay, try to let your left shoulder drop with the weight or with the water bottle. Oh, and I don't know what that did. Just I don't know what happened there. Let your shoulder drop with the weight. And you can see when she does that, how it really decreases the tilt in her head. So that's another example of like a sensory cue. And then I think this is the last one for this person. And just wanted to show you an example of an occupational therapy treatment session. So for her, even though it's cervical dystonia, she had a lot of difficulty with like fine motor tasks. So looking down for a long period of time at her hands was really increasing her cervical dystonia. So we were doing in OT, she was doing some breathing and other nervous system regulation, slowing down the movement, and then rocking. And the rocking chair was a really kind of calming sensory input. So we found that with this combination of breathing, change in sensory input, she was able to do this task at first very slowly, but over time with faster and faster speeds. And she was able to really improve her confidence there with those fine motor movements. last couple is, so sensory cue here. I love this one for cervical dystonia. I do this all the time. Just again, giving your brain more info about where your head is. So she's holding the band, pulling slightly forward, and using that as a cue as she turns her head side to side. That was really helpful for her there. And then this is a visual cue. We said at the very end of her program, I was like, let's try pickleball. I think you can do it. And so we had her first try to just keep her to bounce the ball on the racket. And you can see actually when she's looking at the ball, that visual cue, she keeps her head a lot less tilted than without it. And so just using that visual cue as an external focus was really helpful. So we can see just a little bit as she's kind of walking before, we kind of saw that. So she's walking away. You can kind of see um, so still kind of a lot of tilt to the left side there with her head. That was better. That was the first day, but that was better than what she had done. And here's her walking at the very end and a lot more straight. So she's able to make that improvement over time. And she's actually, I keep in close contact with her. She has said that, she's gone from, only walking about half a mile max to, she actually went on a 3 mile hike the other day. Um, and so made a lot of improvements, getting back to more active lifestyle, playing and baking and crafting with her grandchildren. What a cute goal, right? But that was something that was really hard for her just with the stamina of her neck, and 4 to 9. So she's really made a lot of improvement, and it took a while. I mean, she did 4 weeks there, but then initially she came back about a year later for 1 week, sort of like a boost. And since then, she has been working on it on her own. I talk to her every once in a while just to catch up, but she's been kind of implementing a home program. It's about 20 or 30 minutes a day of exercise that she does, and she's continued to make a lot of progress. But at the end of her 4 week program, I was like, okay, even if it doesn't feel great, I know you tried this and it didn't go very well the first time and it was frustrating. Let's try to play a little pickleball and we'll see how it goes. So you can tell, like you can still see the dystonia, of course, in her neck, but all that we did was, one, we did really decrease how much it was bending to the side to where it wasn't actually, she'd had a fall the last time she tried to play pickleball. So it improved enough that she could do it. But even more importantly, is just she really improved her confidence. And as she's continued to get out there and play and socialize, those things have huge benefits in general. And so I think that has actually kind of helped her, make further improvements in the long term. We saw that already. Okay, last case, I'll run through pretty quick, and then I promise we'll have plenty of time for questions still, just so you can see a couple examples of a different type of dystonia. So this was a runner who, very competitive runner, had been doing up to like 60 miles a week. She had reduced down to 20 and then even 10 by the time I met her. And she was really frustrated. She had just gotten diagnosed. And as I mentioned, that kind of past history of injuries, and on that same kind of right side, it just sort of shows how those limitations and injuries might affect developing dystonia. So she was saying, okay, my goal is to return to running, but also her walking was kind of affected at that point as well. And she's just saying, I'm a mom of four. Like I need to be able to at least like walk and keep up with my young kids. Like they were all between like 2 and 5. And so she, just really hoping to get back to it as much as she could. So we can sort of look here. This was a video from the first day that I worked with her, or from actually the consultation that she was like, hey, I got my camera. Let me look. You want to just see how I run? And you can see right leg like really kind of whipping out to the side like that in a sort of involuntary pattern, obviously. You don't need to worry too much about this, all this stuff, but essentially what we saw was, okay, there's some strength deficits, there's sensory problems, balance is impaired. Let's see what we can do to help this. And so looking at her pie chart, she was here for 4 weeks. We did PT 4 times a week, OT, psych, and yoga each 1 time a week, and trying to reestablish those normal movement patterns. So again, we'll look at a couple examples that I think, regardless of what type you have, should be relevant. So we looked at strength. We said, all right, let's actually address those hip strength limitations that we've noticed you've had. So doing some real like resistance training there. And those aren't going to make super fast changes, but we said, okay, these strength deficits you have, I could very well be contributing to your body's inability to get back to that normal movement pattern. You might have developed these compensations to the point where actually you need to build some strength in order to help your brain move more normally again. And I think that's one thing that I think a lot of people might not have considered or looked at if they're trying to improve, their dystonia, is like, maybe I actually need to improve strength or things like that to help. So that's the strengthening stuff. We also, more strength, so we did a lot of lunges, but also balance. So anything with weights and balance is you're getting a ton of input directly to your brain about, okay, here's where my leg is in space. And when we tested her, she did not know where her leg was in space. It was pretty impaired. She really was like, it was on the pretty high end of like no idea what her leg was doing, which we said, okay, we know there's some specific sensory training we can do, but also working on balance. You're kind of constantly getting that error message back and forth between your body and brain. And once you get to a point of balance, that's actually, showing that they're communicating a little better. So we did a lot of that. We also, working on balance here, we said, okay, let's try to get your hip and your ankle on the other side to work better too, because you've started to move in this way where now that other side is not really moving optimally. So trying to give this cue with the tilt board to tilt her ankle more in the position it should be with her left leg. So then now her right leg is able to step forward more normally. So we're just changing the left leg. You can still see there's a little bit of that kind of turn out and then whip back forward, but not like what we saw in that first video. So that was a couple things. And again, this will be recorded, right? So if you are like, oh my God, so many things, you can always go back and look and get some ideas. This is one that I like to do. A lot of screaming in the background, sorry, but and all we're doing here is again working on balance, but proprioception by saying, close your eyes, and I want you to try and go slowly at first. See if you can move your leg through a pattern where it's actually going straight forward. It's not doing that whip out that we saw in the first video. And she found that doing this repetitively actually helped ingrain that normal pattern back in her brain. If you have really good eyes, or you might be able to see like a little bit of a wiggle still with that right leg, but actually it's going a lot straighter than we first saw. Same thing here, eyes closed. Eyes closed was like a huge deal for her. Again, because I mentioned that that's proprioception was not great. So doing a lot of eyes closed practice really helped her reconnect with her body from a sensory perspective. We did a lot of mirror training. So sort of like watching that video of someone's feet moving normally, using the uninvolved limb in the mirror, you're actually activating the part of the brain that processes information about the other side, because you're getting that image. That's sort of what the brain does to prepare to move, is look at these images. It like have this map in the brain of this limb and then plan a movement. So if you have all those mental reps of normal movement, it really helps. Okay, a couple more, and then I promise I'll wrap up. I'm almost done here. I just wanted you guys real-time feedback of her own feet walking. So more like just like watching the video of someone else's feet moving normally. For her, watching real-time feedback of her own feet walking on the treadmill helped her walk more straight. I've heard from other people too that like doing exercises in the mirror at the gym helps them feel like they can control it better, of all different types, and things like that. And mirroring, if you're like, okay, well, I don't have a runner's dystonia where it's only one side, right? Mirroring could also mean observing normal movement. So let's say you have dystonia in your back, or in your trunk, or your neck even. How can you use this sort of cue to help your movement? You could actually find like a YouTube video, or have a friend or family member record themselves doing something, like maybe it's turning, or drumming, or doing the dishes, or turning a car wheel. something like that, and then you try to copy the movement as you watch the video. So you can definitely use the same principle, even if it's not one-sided. And then this is just another sort of external cue, holding this pool noodle here to say, okay, I want you to try to not hit the pool noodle. So that's the external cue. If I said, don't let your leg whip out to the side like that, that was not working. So, but just putting the pool noodle there, that changed the cue a little bit. And so, okay, what did we get to in 4 weeks, using all those different things? So pretty intensive, right? Lots of therapy, but what did we get to? And this was the before and after. So before on the left, and then the video on the right is her running at the end of the 4 weeks. So you can still see it a little bit, right? I'm not saying it's completely gone, but like pretty better. That's a lot better. So she was able to really improve her movement pattern in just those 4 weeks. And 3 months later, even better. This was a video she sent from home, or I think we did a virtual visit. So now you can see she really has picked up her speed, and it's looking even better. And she's getting back to running at that point like a 10K or maybe half marathon, but eventually was up to running full marathons a year out. So a lot of progress there. Okay, so I am pretty much that's pretty much all of it. I wanted to get through, kind of make sure we saw a bunch of different examples and give you guys some hope and things like that. But I also know there's probably a lot of questions, and I want to make sure we leave some time for that. So if you do have questions, I am happy to answer them. And I just wanted to first also say, oh, to Tony, asking about, yeah, does CBD with or without THC help any dystonias? I figured you meant dystonias, not dystopias. But thank you for clarifying. I think so. There's not a lot of research in this area. I also, am not that type of doctor. I could prescribe anything, even if it was the case. I will just say anecdotally, I've heard a couple people, my patients, say that they have found it somewhat helpful. I've heard some people say they don't. I would guess that that's the case in most cases, that there might not be a general truth where, in general, those things help dystonia, or in general, they harm it or they do nothing. I think it probably is pretty individual specific. Yeah. Oh, okay. And then, well, yeah, Martha, do you want to allow, I can answer these questions in the chat too, but should I stop sharing, and do you want to allow people to unmute and things like that? Okay, great. I will go ahead and wait, or you want to, I shouldn't stop my share yet, right? Okay,